Well, hello and welcome. Now, it's scary living in a country surrounded by others that have reported outbreaks of Ebola. According to World Health Organization, the number of people killed by the deadly Ebola virus in West Africa has risen to 467. 68 of those deaths have been recorded since June 23rd. We had a scare 3 months ago, and everyone took to the panic station. With a collective sigh of relief, we went back to life as usual when the Noguchi Research Institute report came out negative. We have been waiting eagerly for them to issue an official notice of their findings on the newest scare since yesterday. In between both events, did we position ourselves to fight this menace? Are we taking the possible threat of the deadliest disease known to man seriously? And I'm finding out if we are the risk of getting Ebola is closer than we think. My name is Nana Sakwa, and this is PM Express. Risking Ebola. With me to discuss this issue, which is, I think, the most deadliest issue to be discussed in the whole of West Africa, Ebola, is Dr. Apia Crown Labi, who is a medical microbiologist. Doc, you're welcome.
Thank you very much.
And I want to say thank you very much for getting you here at this very sacred time. That shows that you're a doctor. That's a sacrifice and a half. And joining us on the phone later will be Dr. Badusa Kodie, Head of Disease Surveillance at Ghana Health Services. But I'll start with my brother here. Doc, I mean, what is Ebola? I mean, and why is it, you know, and I know you just shared my ignorance on it. You know, somehow I just thought, you know, Ebola was similar to you know, the one that gives you the ulcers.
Yeah, the Bruley ulcer.
The Bruley ulcer. You know, somehow I sort of merged the two.
Yeah.
You know, but, you know, off air you were telling me that they had two different things.
Yes.
You know, so what's Ebola?
Okay, so Ebola is it's a virus. It's a viral disease. Okay, so it's classified. It's one of the hemorrhagic viruses. So it's kind of a family, and they cause hemorrhage when they infect the body. So it's a hemorrhagic virus. So we have other hemorrhagic viruses, for example, Lassa fever, yellow fever, we have Marburg, and then we have Ebola. Okay, so it's a group of viruses which typically would cause hemorrhage. But the problem with Ebola is it's got a very high mortality rate. Okay, and of course there's no cure to it as well. So that's actually what makes Ebola very deadly. But Ebola and Marburg are in the same group. They are all hemorrhagic viruses, but Ebola is the most deadliest.
Now, I don't know what Marburg is, but has Marburg got a cure?
No. So, but it's not as deadly as Ebola.
How about yellow fever? Yellow fever has a cure.
Yellow fever, yes. I mean, you can survive yellow fever. We can prevent it. You can be vaccinated against yellow fever. So it's not as deadly as Ebola, but Ebola has got no cure. So that's what makes it very deadly. So as I said, it's a virus, and then when it affects you, once you get it, the likelihood that you're going to die is very high. So,
I mean, pardon my you know, ignorant questions, but I mean, if we took a tiny dose of Ebola and jabbed you, would your body then learn to resist it, or
no? You develop some amount of antibodies, but definitely most people are not able to overcome it. What we typically would do is we would have to, those who survive have to be hospitalized and then given supportive therapy. I mean, once you are bleeding, you have to be given IV fluids. And the survival rate is quite low. As I said, it's between 30% and 90%, depending on the strain. Although we say Ebola, there are about 4 different strains. We have the Sudan strain, we have the Zaire strain, we have the Cote d'Ivoire strain, and then we have the Restin strain. Different strains predominate in particular areas. Okay, so currently the one that is spreading in West Africa is the Zaire strain, which is the most virulent strain of all the Ebola strains that we have now.
Now, how does this virus just suddenly appear or gather and become a family? And how? I mean, it must have come from somewhere. Or, how does it form?
Yeah, well, we've known of Ebola since 1976. Okay, since 1976. In 1976, actually 2 outbreaks occurred concurrently. There was a first one which occurred, I think, in June of 1976 in Sudan. Okay, so people started getting ill, fever, diarrhea, vomiting, and started bleeding. Okay, and then just, I think, 2 months later in August in Congo, then Zaire, the Democratic Republic of Congo, then Zaire, there was another group of people who also developed the similar symptoms, bled, and quite a number of people died. And that is where the name Ebola came from. So Ebola is the town from which, in Zaire, where the first outbreak came from. There was a river called Ebola. Okay. And that was where the name came from. So subsequent analysis of the virus showed that there were 2 slightly different strains. The one that had occurred in Sudan. So that's where we got the Sudan subtype, and then the one that occurred in Zaire is a Zaire subtype. So it's been there, and there have been outbreaks in the past. If you could remember, in 1995, I think there was an outbreak in, was it Kikwit in Zaire? There's been outbreaks in Uganda as of in the year 2000. There's been outbreaks in Gabon. And most of these outbreaks are the Zaire strain. So it's something that has been there. It's known. So it's not a new thing. Yeah.
The other thing that concerns me, is reading a little bit about it, and it said it's, in fruit baits or whatever that thing is. And, I'm trying... So, but they can resist the virus.
Yes.
So they can be carriers.
Yes. What it is that it's not conclusive. Okay. We have what we call carriers. Okay. They would carry it, but they wouldn't suffer from the disease. So they are thinking that probably bats or small rodents may be carrying it. People tend to say, okay, it's in chimpanzees, but chimpanzees are not carriers because they also tend to suffer from the disease. So if a chimpanzee is infected, the chimpanzee is likely to suffer from the disease and will die. Okay, so we think that it's bats and then rodents, small rodents. Yeah, so we are not exactly sure.
Like Cousier and
yeah, probably.
So does it mean we have to stay clear of? Those who use it as a delicacy.
Well, we haven't had any reported incidents of Ebola in the country. Okay, so we can't make a definite statement because we do not exactly know. Even with what is happening in West Africa right now, they are not able to tell exactly the animal source. What I think now the data shows, they're able to point when it actually started. And you'll be surprised that this outbreak actually started in 2013.
Wow. It
wasn't an outbreak then because they were not aware. It actually started in December, I think early December 2013, where a 2-year-old boy, I think, contracted it first. And this is how it started. So he got it, he died, had bled and then died. And then his sister, also a 3-year-old, died, similar symptoms. Then their mother died. Then their grandmother also died, so similar symptoms. Then when they were buried, all people who attended the funeral, aunties started dying, the nurses who attended to them started dying, then it started spreading. So by March, all these people who had attended the funeral had gone back to their various locations and also started spreading it.
Wow.
So in March, then we started seeing the epidemics because we are having more than there was all of a sudden there was an increase in the number of patients. Then the health services, health authorities were, how do you call it? They were made aware and then investigated and realized that there was an Ebola outbreak. So it's been festering for some time.
I don't know the story, but Africans being Africans, I'm sure they said, oh, the little boy wants to go with his family, so the ghost is taking people away. Instead of seeking medical help,
yeah, probably.
They're probably doing that as superstitious thing. But so who should be prepared? The average citizen or the health center? Who should be prepared?
I think for the preparedness, I think it's for the health sector. Okay, I think for the populace, everybody should be aware. and know what it is about, know the symptoms and all that. But I think the preparedness, it's the health services, because they are the first point of call. And if you are not prepared, you end up actually spreading them more. Because if you've realized, a lot of doctors and nurses who are dying as a result of the Ebola, because once the patient comes in and you do not know it's Ebola and you do not take the necessary precautions, you end up contracting it, probably spreading it to other patients and relatives who come to the hospital, and also you end up contracting it yourself. So health preparedness, it's key.
So what are the first signs? I mean, I'm a doctor and somebody walks in. I mean, what are the first signs to show that, no, I'm not going to touch him?
Okay. Once it's got an incubation period, which is like 4 to 10 days. When I say incubation period, what I mean is that like you incubate an egg. Once you get a disease enters your body, you do not automatically express it. The virus has to replicate, and then it starts causing disease. Okay, so it takes between 4 to 10 days. Now, it starts typically like any other thing: headaches, fever, bodily pains. So you get all those symptoms. Then subsequently, you start having nausea, vomiting, diarrhea. This is severe abdominal pain with diarrhea. Then the bleeding comes in. You start vomiting blood, you start passing bloody stools. Then you start bleeding from all orifices. So your eyes, your mouth, your nose. If you are punctured, you start bleeding. But that's at the latter stage, and that's what makes it dangerous, because most people think about Ebola and all they think about is bleeding. But once you start to bleed, it means you are at the tail end, you're about to go. So when you start getting severe headache, profuse vomiting, profuse diarrhea with abdominal pain, you should think about it.
And at that, so at which point are you contagious, where you shouldn't touch you? At which point?
Once you are infected, you are contagious.
Even when you're incubating?
See, once you are incubating, you are going to, your body is not able to fight it. So definitely you are going to show signs and symptoms. Okay? So during that period, if any of your bodily fluids gets into contact with anybody, the person can also get it. So that's the problem.
How do we educate people so they don't get scared or get panicked? Because I'm sure there's somebody there who's got a cold or a fever by now thinking, oh, maybe I have Ebola because there's the symptoms. I have a headache and I'm feeling feverish, so it might be Ebola.
No. You shouldn't, because Ebola, how do I put it? We haven't had any episode or incident of Ebola in the country, so that's good enough. Okay, so typically if somebody comes to your hospital, you would need to take a history, and usually travel history is important. So in this particular instance where we have an outbreak in the sub-region, if somebody comes and he says, look, I've been to Guinea and I'm back in Ghana and I'm suffering from these symptoms, then immediately you should think about it. Okay, or if there's an outbreak, say, God forbid, in Ghana, and then you've been to a particular hospital and there's been a confirmed case from that hospital, and then within the period the case was confirmed, you were there, and then subsequently you develop those symptoms, then you should be concerned. But if you are in Accra, there's not been any report of Ebola, and you have a headache and a fever, just go to a hospital. I don't think there's any need for anybody to panic. I've gotten a few calls from a few concerned family and friends, and who have keep on pestering me about Ebola. Should we take our child to school? Should we stop? I mean, no. I think life should go on, but we should be aware. And then we should prepare, our health services. We should not be caught unawares. I think that's the most important thing.
Are there any like research, going on to try and find a vaccine for this, or we just praying to God?
Well, so far there's no vaccine. And that's the dangerous thing about it. So far there's no vaccine. I'm sure if there was a vaccine, we would have been vaccinated because most outbreaks have occurred in Central Africa. So most of the outbreaks have occurred in Gabon, Uganda, and Zaire, or Democratic Republic of Congo. West Africa, it's a new thing that is happening. And before, the only reported case was, I think, in Cote d'Ivoire. And that was the Cote d'Ivoire subtype, and it was only one person who had it. Okay, so it's a new thing that we are seeing in the West African sub-region now. But with vaccines, no, up to now there are no vaccines.
Not at all. No antibiotics, no antiviral.
Like I said, when you have it, it's supportive. And by supportive, I mean We make sure your blood pressure doesn't drop because you are bleeding. So we are going to give you IV fluid. If it's blood that you need, we give you blood. If it's platelets, if it's fresh frozen plasma, we try and keep your system alive so that you don't go into shock and then die. And if God is good to you, you've survived.
And there are few that have survived.
Yeah.
Does it mean then you've become immune to it and then you won't contract it again?
No.
If you come...
if you get into contact again, you contract it. There's no permanent immunity.
I mean, why is that? Because I mean, I know it's something like tetanus.
Yeah.
If once you get sort of tetanus and then you come out of it, then you sort of get immune to it. So what makes this different?
Well, viruses are all different, or pathogens are all different, and based on their specific characteristics, it's like HIV. Well, HIV, we can't cure it, but okay, well, HIV may not be the right example, but there are certain, it's not all viruses, because if all viruses were the same, then we'll be able to develop, vaccines against all of them. Those that infect you and your body is able to develop immunity and forever resist that, how do you call it, virus. For those particular viruses, you are able to develop a vaccine, because once your body is able to develop immunity, prolonged immunity, then anytime you introduce a similar either viral epitope or anything of that virus into the body will automatically generate antibodies against that virus. So that's why, but you're not able to do it against all viruses. Okay. It's certain classes, and based on the virus's characteristics, whether it's got the right, we call them epitopes, or it's got the right antigens that is able to stimulate the body to produce the required antibodies.
I've got Dr. Budusa Kodie on the line, so maybe he can educate us how the nation is, preparing itself against this. Doctor, hello and welcome.
Thank you very much, and good evening.
Well, Doc, we are looking at Ebola virus, and we're trying to look at the education part of it, both from the health services and then the citizenry, how to arm themselves. Now, with regards to the nation, I mean, are we educating people enough to be aware, like if you have relatives who've gone into Ebola zones, what to do and not what to do? What are we doing?
Well, thanks very much. The education, that is part of what we are doing now. There are also systems in place to use the various communication channels available to let people know what the disease is and how to prevent and protect against it. I'm aware that within the districts, we do a lot of community education that includes messages to organized groups to talk about the signs and symptoms and how to prevent the condition. Hello?
Yeah, I'm listening.
Yes, and also with the national level, using the television and also the radio masses to talk to speak to the condition. So a lot of panels are being used. I'm aware that some pamphlets and leaflets have been developed. So not adequate, but then there's a need to print out 4 copies of this. So some preparedness are already in place, and what you can say now is to indeed step up these activities. So that is the issue with the education.
Dr. Sakode, let me come. I mean, you talk about districts now. Folks outside of Accra, how like their delicacy, which is game. They want to go out and hunt for game. Now, there's all suspicion that bats and rodents may harbor these virus. And if you go out of Accra, this is a delicacy. Are we warning them against it or teaching them how to cook it so the virus doesn't stay in it? What are we doing with them?
It's clear now that the transmission, the major mode of transmission now is person to person. This is not to say that from animal to person is not possible. As much as possible, the transmission from person to person is a major problem now, and that is where the attention now is being directed towards. We are aware that the bats are the natural reason why, and that they can have the infection without being diseased, and that they need to stay away from those animals that could contaminate the human population. But now the biggest danger is transmission from person to person.
Transmission from person to person. Has Noguchi brought the final result for the Nyaho panic?
I believe that your media might have received it, because right now the Ministry of Health has released, come out with a press release clearly indicating that most of the media houses have received a press release, and that is the situation now, and that the test is not positive for Ebola.
So the protocol now, if anybody goes to a hospital with a cold or something, I mean, should you ask them, have you been to Guinea, have you been to Sierra Leone? You know, is that a protocol to make sure that the case you're dealing with is not, you know, Ebola? Or
travel history is one of the major components of taking history from patients with infectious diseases, and that is not the only way to find out whether somebody has Ebola or otherwise. But if you present with symptoms that could be a suspected case of Ebola, it's important that we ask about travel history.
This is, it's obviously one of the deadliest diseases with no cure in sight whatsoever. I mean, could it be too late if I've walked into the hospital and the nurse has looked at me, touched my forehead, gave me a jab? I mean, by that time, it's too late. What then happens?
But the point is not clear. Come again, please. What is too late?
If I walk into a hospital today and I happen to have this virus, I mean, by the time the nurse has done his, the first aid and everything, it's too late. Contamination has started. How do we prevent this?
And that's you think that it's too late that the...
Well, I might have spread the disease, I sit in a taxi or sit in a trotro, the nurse would, hold my hands.
Okay, now, but if the person with the symptoms which are obvious Ebola or and that they go to the hospital, there is too late. Okay, that's quite true. But then for now that we don't have case in the country, the first sign it would take a bit of time for not to. There are a lot of conditions that simulate Ebola, and that we cannot test for Ebola for every situation of fever, every situation of muscle pain, and usually the first diagnosis takes a bit of time, and the high index of suspicion, which is very important. And then when there is evidence that the person has come in contact with a suspected case, a probable case or confirmed case, then any symptoms from the various pool of syndrome should be considered as a possible case or a suspected case and need to be investigated early. So high index of suspicion is very important, and this is part of the training that are given to the medical staff and the staff that attend to patients and for that matter clinicians.
Again, just one more question before I take a break. How are we going to treat it carefully so that the patient also doesn't feel, like a prisoner or like literally a victim? How do you treat? Where do you find the balance so the patient doesn't feel even extra more demoralized, like, you are now a castaway and you're going to be thrown into the dungeons. How do you do that?
That would require professional approach to the condition, and as much as possible, for every patient, you give the maximum that is required to provide support to the patient. We are aware that there is no definite treatment for this, but then the support treatment is very effective, could be very effective. So as much as possible, all that the patient requires must be provided. If the patient is losing fluid and getting weak, immediately the fluid and electrolyte balance should be maintained, and whatever required with regards to fluid infusions has to be provided. If the patient is bleeding and getting weak because of the blood loss, and life is being threatened because of the blood loss, all that is required with regards to transfusion has to be provided. So what is lacking is the availability of antiviral agent to move away or kill the virus. But there are other supportive measures that could be done to get the patient, support the patient.
Okay.
Keeping the patient in isolation, that is quite, well, I wouldn't say it's a bit too far, because as much as we are protecting or helping the patient, you also have to protect other people. And because it's highly contagious disease, that is the need to keep the patient in isolation so that others would also be protected.
Doc, I'm going to take a break here. When I come, the medical staff, you're doing your best, but then we want to find out what the borders are also doing. Are they also, making sure that people moving in and out are not coming from dangerous zones? And if they are they reporting to the health services? Stay tuned. We're going to come straight back.
We don't have the capacity and expertise to do that. It's Port Health. They would have to try and track the person's route till the point where if we have to prevent the person from entering, at the point where he was prevented from entering, or if he entered at the point where he was identified and then isolated. I think Port Health are better placed to do that kind of investigations. For us, our mandate is clear. It's about security and ensuring that persons who come to this country are persons who have been authorized by the visa issuing authority to come into the country. Otherwise, once you don't have the visa, the passport, the necessary document, we will not admit you. We need to know who is coming in and who is going out. But when it comes to health-related matters or even narcotics, we do not have the expertise to deal with that. So what we do is to identify routes. We are able to read a person's journey by looking at the stamps. The arrival and the departure stamps can help us read a person's journey. So if we think that you fall within the category that has moved within a certain zone we consider as a problem zone, we can alert customs that we think this traveler should pay a close attention to this traveler. So we can help us in giving information, but as to determine the route that an infected person has applied is not within our mandate, and we also don't have the capacity to do that. As I speak, the Ministry of Health, through its agency, the Port Health, are already in partnership with all the border security services, SEPS, Immigration, National Security, BNI, and all those other relevant key stakeholders operating within the border area. So there's this border security structure which they are part of. So I would say there's already that partnership. What is needed now is the material or the education that must go with the crisis. That has to be forthcoming. The partnership already exists. It is when we are giving leaflets, we are giving information, we are told what steps to take when you encounter a person like this. Those are the most essential things that agencies working along the borders will require to be ready to assist. But with mere partnership or partnership without these tools, I mean, it will just be, I mean, work and business as usual.
Well, there you go. That's Mr. Palmdetti of GIS saying that, look, they don't have the expertise to find out who's ill and who's not ill coming in and out. And obviously, if we don't have the disease, it will be coming in, and you would expect, you know, the border guards to somehow pick it up. I don't know, does the health service then post people to the borders to pick this up?
I don't expect the border guards to have the expertise to pick up the disease, okay? And you may not even be able to pick it up because the patient who is coming in as a traveler, and he's not going to come and tell you that I have a headache or have this. And the person may not obviously be showing signs of hemorrhage or anything. So, because at that point, the person would need to be in a hospital. So typically, the person may be walking through as a normal person, and most likely you wouldn't be able to pick it up. So it will be difficult for, that is why, I mean, you realize that the WHO has not placed any travel ban or any trade ban restrictions on any of these countries, because it will be difficult because the patient will walk in asymptomatic without any symptoms. So that is why when you have a patient somebody who has the symptoms, it's important to take a travel history and find out if the person has come from one of these countries. And that's why, as I said, the high index of suspicion, as Dr. Barima Osei Asare was saying, is very important. And so you need to train your clinicians or send out the message as much as possible.
Should we test, you know, at least the blood pressure or temperature of everybody coming from the hot spots, at least come and get your BP checked or your...
That is logistically not possible because people with malaria may be having a fever and may be having the same symptomatology. So that you can't do. And to test everybody for Ebola is also not practical because it's quite expensive and it's time consuming. And whilst you are testing the person, what do you do to the person? Do you allow the person to go? So it practically may take a day or two to get your results back. You hold all these people, travelers, in limbo. No, it's not possible. It's not feasible.
If they have a temperature, then you hold them.
You see, for something like SARS and all those ones, of course, at the airport, you could do that and then do a quick screen or hold them because, of course, there are a few, do you have a cold, do you have that, because, of course, that was acute and it could spread by aerosols. But this particular one, logistically, it's not possible. And you may keep so many people and your system will just... we can't sustain it, so it's not possible.
Let me, Dr. Barima Osei. Hello, Dr. Barima Osei.
Yes, good evening, I'm online.
Good. I was trying to screen everybody who comes in from the hot zones, but I hear logistically it becomes very, very challenging. But do we have isolation centers, and which hospitals have them, just in case?
Ideally, all the isolation centers should be readily available at the regional capitals. That's what we have planned initially. And then the areas of Cotton where the population, a lot of people live. But we are not having all these things as expected. So honestly, there's a need to step up our isolation facilities within the health sector. And that the big facilities that are likely to see cases when they happen should have proper designated isolation facilities and be equipped with the records.
No, are you saying we don't have them yet?
Well, we have some isolation facilities, but it's not the optimal type that we expect. So we need to enhance on that. We need to develop on that further. And that is we have started a system to get that in place, and as much as possible, we need to improve on that.
Look, I mean, we are talking Ebola, and I remember the little girl, who we suspect there was a suspected case in Kumasi. We all thought it was Ebola, and we all jumped. So from between then and now, and then we have the Nyaho case. If we still haven't got isolation centers, because at the moment I think that's the only hope, since there's no cure, is just to isolate. Then we are really lacking behind on this one.
That's quite true. So we still need to double our steps with regards to adequacy of isolation facilities. That's the fact.
I mean, I'm not very medically inclined, but is it not just an empty room with beds that nobody else goes in? I mean, is it a lot to ask for? I don't know.
It's not just simple as just getting an empty room. How do we set aside the fire within the? It should be separate from the rest of the facility, and as much as possible, not easily linked up with the rest of the facility. So getting some room is fine, and but then it goes beyond just just the space in a room. That we call it an isolation facility. That if we are talking about supportive care, what supportive equipment is available, if what facilities are there to provide all these things. So indeed, there is a need for further enhancement of this situation with regards to isolation facility in particular.
Look, but isolation facility will not only be for Ebola. I mean, it could be for any disease that's contagious. And are we saying that all these years we haven't had isolation centers just in case, maybe tuberculosis? I mean, you need to be isolated for something like tuberculosis. No. Oh, my.
What we need indeed is an infectious disease facility or hospital, and that should be the mid-term plan. As a country, we have to work forward. And that would provide all that is required to manage the infectious community adequately without any contamination to the environment. The patient there will get the best of care, and also provide the necessary preventive measures and protection for the rest of the population.
Doctor, if we get a case tomorrow, a positive case tomorrow, what do we do? I mean, because we don't have a, I mean, where do we take this patient?
This test case has made people redouble their efforts, and now I'm aware that at the big centers, active processes, active efforts are ongoing, and this has made people start better, and we are improving on our isolation system.
Which are the big centers, Doc, if I may ask?
No, well, I mean, now Koibu now clearly has designated a place which is being quickly developed. We have been to 37. They showed us yesterday an area they have designated which is also being developed, and the other few areas. So the service and then the ministry doubling our efforts to get the isolation facility.
Do we have one, like, say, in the airport, just in case somebody turns up hemorrhaging? Is there one in the airport, or then we have to put him in a car and drive him to 37?
The airport clinic is a designated place, and we have come in agreement with the airport management, and we are aware that they have a place for that purpose.
Doc, again, do you have any link between yourself and Immigration and Border Control and Customs, just in case, people are traveling within the hot zones, spot them before it's too late? Is there any link, or there's nothing we can do, we just have to sit and wait?
The link is through the portal staff, and they work closely with the GRA and other, the immigration staff. So the portal staff are part of the health system, they're part of the surveillance system, they're part of the public health system, and they are watching for or keeping surveillance or supporting with surveillance activities at the various points of entry.
Okay, Doc, even though we don't have the disease and our neighbor countries have it, are we, helping them to educate themselves? What are we doing to help them so that, they also, because if we sit and say it's not here, they will eventually turn up. Are we doing something to help them sort of contain it and probably eradicate it?
Yes, recently there was this international conference here in Accra that was not more than a week ago. And Ebola has been identified clearly and being considered not as a problem for the affected countries alone, but we are seeing it as a regional problem, as a sub-regional problem and as a regional problem. So as much as possible, we are pulling together efforts within the sub-region to combat the situation, and that the various ministers within the various heads of state or the president together are working, and those areas that are affected, with regards to resource, those that are a bit more endowed, providing support to those that need to be supported. And then when it comes to sharing technical expertise, there is exchange of technical expertise and sharing of technical expertise. So as much as possible, those countries that are affected are not left alone, and the whole region that are managing the situation for now.
Okay, Doc, hold on for me. I have Dr. Apia Kranlabi also here in the studio. Doc, so at the moment, if you put a patient on a bed and you treat them, after you need to burn the bed and everything? Or?
Well, yes. I mean, once you have a confirmed case, then as you were saying, you need to have an isolation room. You need to have protective gear, because anytime you go in fully gowned, okay, and if the patient passes away, you just don't bury the patient. You need to decontaminate the body. Funny enough, the virus is a very fragile virus. 30 minutes exposure to a temperature of 60 degrees Celsius would kill it. Oh. Putting it in 1% formalin would kill it, because it's an enveloped virus and it's quite susceptible. So you need to decontaminate the body. That has been the problem in Guinea, for example, because once the patient dies and the family want to bath the body, they want to grieve, they want to touch, that is how you spread it. So if a patient dies and it's a confirmed case of Ebola, I mean, the body is not handed over to the relatives. It must be decontaminated and then buried safely. Whichever room, whichever bed must also be thoroughly decontaminated. Those are the things. You have to decontaminate wherever known cases, because there may be remnants of whatever effluent discharge, and that may be a source of the infection. Yes, so you have to do that.
So you can... Why don't you have an edible formalin?
Pardon?
You don't have edible formalin that you can drink and kill the virus.
If you drink formalin, it's going to kill you. It's going to fix your system. So no, so you can't do that.
Viewers, pardon my question, but I'm trying to find a medication. I'm going to take a break, and then when I come back, we'll continue the discussion. Stay tuned. Well, serious case of Ebola, and that's what we are discussing here. And it sounds quite deadly, since there isn't any cure for it, and I think it's very scary knowing that you could easily catch a disease and there won't be any vaccine or anything for you. But Dr. Badusako there, Doc.
I'm online.
Good. Doc, I mean, the other thing I want to find is, I mean, do we have like a trained team, the Ebola team, where if something happens, you have, 5 doctors with these 20 nurses that move in to sort the situation out? Or are we leaving that every doctor in every clinic should do that job? What are we doing?
It's important that we have designated teams that are well trained to and we also enhance their capacity to manage the case. The assumption is that we doctor should be in position to manage some general to some extent.
But so are we saying that every
that we train some people and enhance their skill and knowledge specifically for this, so that these teams would move to support others that are managing it. And that is the non-specialty situation. If every doctor has to come on board, this will be the supervisors. But then we hope that we don't get this far. As much as possible. It's important that we get people with additional expertise and knowledge.
Doc, let me come in here again, because from what you said, I mean, as soon as somebody has Ebola, you know, we have to be fully gowned, and you've talked about the blood and the fluids and all that. Now, if any nurse or any doctor suspects any case like that, they're not going to go near that patient. So they would have to have, you know, an Ebola team that you can call, and they should be there in the next 20 minutes to do all that covering up, and probably even taking the patient to a designated isolated center. So if that team isn't ready and the isolating center isn't ready, then we are really behind on preparation.
Patients don't walk to the facility saying that I'm a case of Ebola. First, somebody has to detect it and then adequately diagnose the condition. So as much as possible, it's important that every health worker or every clinician, we are quite alert with our infection preparedness and response knowledge and skills, and put them to use. But then as soon as we realize this is attention, that is to the place of isolation, where more stringent barrier nursing, more stringent infection prevention and control measures, and the way ST has been seen, you completely done as the earlier speaker mentioned. So it's important that we get designated teams who are more knowledgeable.
But have we got the team, though, Dr. Sarko? Have we got the team? Is there a team?
Teams have been formed and some of them have been trained, and the rest, others are being trained.
Okay, and is it a team for every region, or is it one for nationally?
It's not one team at the national level. The regions have been informed to build their teams. So there's a national chain of trainers, and then moving down to the regions, and then subsequently there will be the district training for the district team.
Okay, thank you very much, Dr. Sarkodie, and I'm sure we'll engage on this issue again. It's a bit, I think we are treading a bit too careful or treading a bit too behind. You know, if we haven't got the isolation centers ready, and you know there isn't a Ebola team which you can call, you know, 911 Ebola, and then they come running, then we are, you know.
Yeah, I guess it's good. We are getting these issues. I mean, a few patients with symptoms coming up, so that we are actually awakened. I mean, so that we know where we are, so we can actually prepare. So it's been good. It's good that at least all these two cases have all turned out to be negative, because if they were not negative, then probably we cut pants down. So it's good they are negative. At least now we know what to do. But I hope we act quickly, because I hope it doesn't come into the country. But with all these, I think we need to really act quickly and get our acts together, because if we've been warned.
Because from what I deduce from my little education is that because there's no vaccine, you have to contain it.
Yes, you have to contain it. That's what it is. You see, it started in Guinea, then it went to Liberia, then Sierra Leone. You see, so the only how do you call it, that is what is buffering us now is Cote d'Ivoire. Okay, because Cote d'Ivoire shares border with Sierra Leone as well, and I think Guinea. I'm not quite sure, but I think shares borders with Sierra Leone and Guinea. Okay, and then Guinea shares borders with Mali, and then Mali shares border with Burkina Faso. Okay, so there are so many routes through which it can travel into our countries. So I think we really need to be prepared. If it's gone to 3 countries, it can just jump.
You are in the medical field. I mean, is it big, or do you just get a dedicated team and say, listen, this is your job, these are your gear, these are your blood, this is your fluid, stand by, when I call you, that's your van, move. I mean, or it takes longer than that?
Well, it's not as simple as that. One, you need to get people who are willing to do it. Because despite the fact that everybody is a doctor, it's not every doctor who is going to jump and say, hey, I want to be a member of the Ebola team.
About, I mean, would you do it? Because you seem to be a bit...
When given
the gear and the car and everything.
If I'm given the proper training and I'm insured, because of course you'd have to insure me, I'm not going to do this. You'd have to be insured because I'm putting my life there. Once I'm given the proper insurance, I'm given the proper training, the proper gear. Of course, it's a job somebody has to do, so I wouldn't mind.
Thank you very much for the education. And yes, motivation, motivation, motivation. You need to motivate the medical team, and they will be up there to serve their country. But I think isolation camps, we know that now we need them, and then we need a dedicated team that are well motivated and insured, so that if anything comes, they will stand up to the call. As I always say, thank you very much for watching. Tomorrow we'll be back to do it all over again. And Doctor, thank you very much again.
You're welcome.
Cool.